Hello, everyone, and thank you for joining us for today's webcast, Obesity, Costs and Impacts in Canada. My name is Andre Picard. I'm the health columnist at the Globe and Mail, and I'll be your moderator today. Before we get started, I'd like to acknowledge that I live and work in Vancouver, which is on the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. Now, socioeconomic status, gender disparities, and regional differences often shape the prevalence and outcomes of obesity. These factors, combined with the stigmas directed at those living with obesity, make managing what is increasingly viewed as a chronic disease even more challenging. These days, we can't talk about obesity without talking about drugs. GLP-1 agonists are hailed as game changers, but they're only one part of a broader picture when it comes to weight management and healthy living. Today, we'll be discussing how treating obesity as a chronic disease can prevent a range of other health conditions and reduce costs to Canada's economy and health system over the long term. At the end of the panel, there'll be some time for audience questions, so please submit your questions using the virtual Q&A box, and I'll try and get to as many of them as possible. On behalf of the Globe and Mail, I'd also like to recognize Eli Lilly Canada and Obesity Canada for supporting today's event. So let me start by introducing our panelists. We have a great group of three panelists today. I'll start with Hans Kruger. He's the president of H. Kruger and Associates, Inc., and an adjunct professor at the UBC School of Population and Public Health. Welcome, Hans.
Thank you so much, Andre. Yeah, I'm Hans Kruger. My background as an epidemiologist and a health economist. My interest in this area goes back about 15 years, where I spent a chunk of my research efforts looking at the economic burden attributable to a number of important risk factors, including excess weight, of course, but also alcohol consumption, tobacco smoking, physical inactivity, and low fruit and vegetable consumption. But of course, today's focus is on excess weight or obesity.
Yeah, and we'll tap into that knowledge in a minute. We'll just introduce the others. So next I'll introduce Lisa Schaefer. She's Executive Director of Obesity Canada. And Lisa, you also have a long history in this area.
I do. Thank you so much. As you said, I'm Lisa Schaefer, Executive Director of Obesity Canada, and I'm a passionate advocate for improving obesity care and reducing weight bias. I bring both professional experience and my personal lived experience to this work. And at Obesity Canada, we're really focused on changing the narrative. We want to see a shifting narrative around obesity from one of a moral conversation to more of a medical one. And we really champion evidence-based care. We drive policy change, and we're working to ensure that people living with obesity are treated with the same urgency, dignity, and compassion as anyone living with a chronic disease. So really excited to be here today and excited for the conversations, because that's truly what makes change, is real talk.
Great. Thanks for joining us, Lisa. And finally, we have Dr. Megha Podar, a specialist in endocrinology and obesity medicine. She's medical director at the Medical Weight Management Centre of Canada and an assistant clinical professor at McMaster University. Thanks for being there too, Megha.
Yeah, absolutely. Thank you for having me. I live, eat, sleep, and breathe obesity medicine. I see patients every single day, so I tend to have my clinical hat on quite a bit. But as an author of the clinical practice guidelines, I'm also really passionate at building scalable solutions. We live in a publicly funded healthcare system, and obesity is a significant challenge within that system. So a lot of my passion is building accessible models for people who don't traditionally have the access to obesity treatments.
Great. You all give us a lot of questions for me to ask, so I want to wade right into them. If I could, I'll start with you, Hans Kruger. I want to start with some big picture stuff. Maybe give us a sense of the economic burden that obesity places on the healthcare system and society more generally.
Yeah, our latest estimate of what the economic burden is attributable to excess weight or obesity is about $54 billion. Now, that's a big number, so let's put that into some context. This year, we are projected to spend about $63 billion on national defense. That's an increase of about $9 billion. So last year, we spent about the same amount on national defense as is the economic burden of excess weight.
Wow, those are big numbers, and these are direct health costs and indirect costs, both of them put together.
Yeah, absolutely. There's two components to this economic burden. There's the direct costs, and then there's the indirect costs. The direct costs are, the costs that are attributable to, hospitalizations, physician services, drugs, and so on. The indirect costs tend to be things like disability that's associated with excess weight, and also premature mortality that comes with excess weight.
Okay, and we'll get into some of this stuff in more detail a little later on. Lisa, your group, Obesity Canada, published a report recently that had some slightly different numbers, but you also had this important message there that there's a cost to inaction, to not tackling this issue.
Absolutely. We came out last year with our report, The Cost of Inaction. And within that, we understood, the study that we did was about 27 billion. And to echo what Hans was saying, we know a portion of that is that direct healthcare cost. But what's really interesting to us is that indirect costs. And that was coming out at about 21 billion. And when we look at that and we think about that's a reflection of a bunch of lost economy, a lost passion, lost people, lost livelihood across Canada that really could be met in a different moment now, and a really big opportunity. I often say the problem feels big, but I think the opportunity is even bigger.
And it's not just about money, though. It's a loss of quality of life, a loss of enjoyment of life, etc.
Absolutely. There's so much loss to the economy. There's loss to our goodwill in society, especially when I think of the double disparity. What our statistics show is that we know that women have a double disparity. We know we're going into the workforce already earning less. When we show up and we're living with obesity or living in a bigger body, we earn even less than that. So we know this is serviceable. We know that there are solutions now, but what's really our biggest challenge is that we're rooted in this stigma and bias, and our systems are built around stigma and bias that have that pejorative belief that living with obesity or living in a larger body is really about somebody being lazy and not understanding. And that's because we've seen it as an issue of willpower. And we have more evidence now than ever to show that it is so much more complicated than that, and that really diet culture has been lying to us for generations.
And we'll try to dive into some of that complexity as we go along today. And I'm sure the audience they're already starting to send us some questions. So it'll be interesting to see what they're interested in. Now, Dr. Mega Potter, we're going to talk a lot about treatment today, a little bit later, but I want to start with the backing up and have you talk a little bit about prevention. Are we doing enough to prevent this economic cost, the burden on people? Are we doing enough upfront?
Yeah, it's a great question because often we separate out the concept of prevention and treatment. And I actually think that they are intertwined because there's actually no country in the world that has successfully done any intervention that has been shown to prevent obesity. So when we talk about, have we done enough? Well, what are we actually supposed to do? We don't even have the data to support what tools are actually effective for preventing. The only time we've seen success at preventing obesity is actually by treating it. It's kind of an opposite thought process, but when we treat obesity, all of a sudden, that person, if it's a young reproductive female, when they have a baby, the chance of that baby having obesity is far less because now they don't have obesity. So we almost need to start by treating and understanding what the definition of success of treatment is in order to then work towards prevention. A lot of the time when people think about prevention, they think about the environment and the food environment and kind of what role does that play. And my answer is always, it's not an either or, it's an and. It has to be an and. We will not be successful at preventing obesity if we don't treat it. And we won't be successful at treating obesity if we don't look at prevention. So it has to be both.
Yeah, in the AIDS field, they use this expression treatment as prevention has become the way of tackling it. It sounds like something similar is needed in this field.
Absolutely. And I think that, to Hans and Lisa's point around the economics of not treating, it's very funny that, what we look at when we think about treatment is we think about weight loss. But actually, everything that was just quoted, disability, quality of life, stigma, that actually has nothing to do with weight loss. And so when we think about treatment and we think about prevention, we're not talking about making people smaller. We're talking about treating this chronic disease of obesity that's leading to other health issues. And so, it's more about the definition being about how many pounds did I lose versus how much do I feel better? How much more can I move? What are my other health complications that are getting better? unless we start to tackle the treatment problem and assign the right success number to those outcomes, we're not going to even be able to show that we're successful with treatment.
And I'm going to come back to that later and probe you more about what success means in this field.
Sure.
But I want to come back to Hans, the number guy, to give us some more context. There's a lot of alarming data out there about obesity. 60% of the population is overweight or obese, etc. I'm wondering how good are the data? We know they're often based on BMI. Is that a good way of measuring? Could you talk a little bit about the numbers game, if you could?
Sure. Yeah. I mean, BMI is sort of the standard way that has been used by researchers for decades. It's not necessarily the best way to identify individuals in this way. There are other ways, such as looking at waist circumference, hip to waist ratio, portion of fat, etc. But BMI is a standard that is used. One of the challenges with BMI is that you need to understand or need to get an individual's height and weight to calculate it. And one of the problems is that people will tend to overestimate their height and underestimate their weight. And in doing so, you get sort of a wrong BMI number. Now, we know that already in the research world. So now we can do adjusted, self-reported BMI. An example is, I'm 6'4", let's say, and I weigh 210 pounds. My BMI, therefore, would be 25 point something. So that's just barely in the overweight category. But let's say I'm really not 6'4", I'm actually 6'3", because I overestimate a bit, and I haven't weighed myself for a while. I'm actually 225 pounds, not 210. And so my BMI goes up to 28 something, right? So that is one of the issues within this world of research, but there are ways of adjusting for that now.
I thought people only lied about their height and weight on Tinder, but I guess they do it more generally.
No, even the president of the United States lies about his height and weight.
I'm shocked. I'm shocked to learn he's not always truthful.
Sorry.
Now, Lisa, when we talk about overweight and obesity, there's lots of blame that gets tossed around. You alluded to this in your opening comments. Can you talk a bit about the complexity, the socioeconomic factors that come into this beyond eating? It's where you live, how you live, etc.
Absolutely. And when we talk about these numbers, Hans's numbers or our numbers from that cost of inaction study, what we know is at least 1 in 3 Canadians are living with overweight or obesity. We also know, as we've said, this is generational. So obesity really does impact all Canadians, but it doesn't impact all Canadians equally. And that inequity is really a big part of the challenge that we have in front of us. We know, as I said before, women make less, lower income households, and certain provinces bear a really disproportionate amount of that burden. And that has to do with that strain on access to, whether that's to the food systems as much as it is to these potential drugs. There's lots of different things that come into it. We know that socio-economic status is a major driver. People in lower income brackets face a lot more barriers, as I said, to that, getting nutritious food, mental health, activity, all of those things. There's so many social determinants of health. But one of the big social determinants of health that we're not necessarily talking about is that stigma and bias, and how it is baked in at a systemic level as well. So whether I'm in a low income or higher income, I might still not receive the best care because of that stigma and bias component as well. So right now it's a real crapshoot, and it's unfortunate because it's a real patchwork across Canada what obesity care looks like. But if we know the magnitude of the challenge, we should probably kind of stabilize and get a national framework and get some supports and start educating people along the way, whether that's the general public or our healthcare practitioners as well.
So talking about treatment, what's the ideal? If you had the ideal system, what would you want for patients?
Oh, I would love collaborative care. A solid collaborative care model, I think, would be the route to start with all humans, anybody having a chronic disease, and really all Canadians really could benefit from having collaborative care. I'm sure Mega would agree with that. But we need to start by having evidence-informed providers. And whether that's a clinician at a blood clinic, whether that's I'm getting an x-ray, everybody needs to understand that they don't understand obesity as much as they probably thought they did. Again, diet culture has been really loud. We now have more evidence and science. Obesity Canada is proud to produce the clinical practice guidelines on the treatment of obesity. We have both a pediatric and adult version That's a really long document. I don't expect everybody to read. Megan might have Post-its on hers, but there's few people that will go that deep. So we really need to move to implementation and really helping make it approachable and getting people up to speed. It's fair. We also need to give everybody the space and grace to catch up to this because we don't teach it in medical schools today.
And Megan, maybe I'll throw that same question to you. Ideally, what should someone who wants treatment, what should they expect? What's the ideal if you could offer it?
Yeah, absolutely. I think the ideal is a holistic approach where there's a clinical pathway that this person knows that they have access to. It's within the public system and it has many tentacles. So the challenge with our system right now is we're so siloed. If me as an endocrinologist, if I'm your obesity doc, then that's just me. It's me and my dietitian seeing you. But what we need is a full sort of gamut of counselors and psychologists and exercise physiologists and dietitians all on board to be addressing the problem in the same way. To Lisa's point, even though you might see a psychiatrist or you might see an endocrinologist for obesity, you're probably not getting the same conversation. There's no standard of care that has been implemented on a system-wide level in Canada. And so people are not getting equal levels of care, even if they're able to get into their family doctor, which is a challenge within itself. The other thing I'll sort of say is that, yes, obesity is a chronic disease, but it's different from all other chronic diseases. It's not like type 2 diabetes and hypertension. Majority of time that people are living their lives are outside the healthcare system. 99% of the time, they are not accessing the healthcare system to be actively treating their obesity. And so the support needs to reflect that. It can't just be the doctor that's involved in the care. It has to be on a system-wide level, whether that's access to nutrition or access to ability to move your body, or it's just support tools. With technology and digital tools, there's just so much more we can do to support people outside the healthcare environment, because that's majority of where people are going to be living with this disease.
And are people reluctant to go get treatment? Do people just say, well, I'm overweight, that's life, so is everyone else in my family and my neighborhood? Are they reluctant to go get help that they could benefit from?
Absolutely. I mean, I think it's changing, right? But the reality is that stigma and bias that Lisa mentioned is a barrier to actually accessing treatment. So what happens when you live with obesity, you probably live with obesity for at least 10 years before you're getting treated. And in those 10 years, you're getting exposed to all these sort of microaggressions of systemic bias. You're walking on the subway and nobody wants to sit beside you because you're in a bigger body. It's all these sort of small things that add up time after time. And then you internalize it to not feel so great about yourself. And that internalized bias is reflected on, I don't want to go to my doctor. My doctor has way more important things to do. I'm not sick. I did this to myself. I need to figure it out myself. And so then what ends up happening is we see people presenting too far out. They already have complications related to their obesity because they didn't feel like the healthcare system was a place they could go when they had that first idea that, my weight might be impacting my quality of life. So we know there's a big challenge with stigma that leads to people not accessing care. But even when you do access care, you might not actually get what you think you were deserving of. A lot of time that stigma even exists in the doctor's office, where the doctor will sort of say, well, have you tried this diet? Or, well, just eat less and move more. Like, obviously you're doing something wrong. And you can imagine somebody, got all this internal strength to go and talk to their doctor, and then they were just shut down. That person's probably not going to come back very easily. So it's kind of a multi-systemic challenge that we're experiencing that's leading to poor access.
Now, Lisa, I see you nodding vigorously at everything that Meg is saying. You must hear this a lot from members of Obesity Canada, the reluctance to get care, the difficulty getting care. Can you talk a bit about that?
Absolutely. Yeah, it's heartbreaking stories that we hear out there. And I will say as well, I want to give a shout out. There are a lot of healthcare professionals out there trying to get this right and do this right as well. Part of the challenge there is we don't have billing codes. We don't have systems for them to be able to provide the kind of care that's needed for someone living with obesity. So I want to level set that as well. But definitely patients are being asked to navigate a system that isn't designed for them, that doesn't really have solutions for them in mind, and where we have that really internalized bias, as Mega was talking about. I often talk about it as even just the thousand little dignities that we're robbed of largely through our life. There's a difference between sitting down and knowing that a cuff or a blood pressure monitor is going to work on my arm, or someone shouting down the hallway, I need the bigger cuff, right? Like it's small, but it's big. It just makes you always feel like that asterisk, like that special use case or that problem that needs a different solution. Somebody's now got to go out of their way and get that extra moment for us. So we hear that all the time. And when you have those negative impressions from an early age, which is something that I can reflect on and say was part of my experience, there was conversations that were being had around me, but not with me. Could it be polycystic ovarian syndrome? Could it be prediabetes? And it was never any of those things. And then I was just left with this belief that it was, okay, then it's just me and I am the problem. I was there before Taylor Swift was. It's me, you guys. I'm the problem. And I also need to be the solution. So then I turn to the loudest pieces that I can see, which are often these glossy magazines, or the loudest thing that I can hear in the narrative, in the social culture that I hear or that I see my friends doing. And I'm doing the same things. I'm counting my 10 almonds. I'm working out. I'm doing these things and I'm not getting the same results. It's a very compounding and very isolating place to be, which is also why we're really passionate about connecting people with community and helping people see there's a multitude of people who do understand this. And that's where that collaborative care model also really pays off in full.
And it starts young, right? With kids, it could be particularly cruel to kids who are heavy.
Yeah, absolutely. We have research and evidence that shows that as well, how young kids are when they're choosing not to be friends with somebody who looks like they're in a bigger body and what their beliefs are around that. And we learn that from our fairy tales. I love one of our big key opinion leaders in Canada, Sean Wharton, often talks about the Little Mermaid and that like just ingrained knowledge that you have that Ariel is this slight little beautiful thing. And then Ursula is this big and like she takes up space and is evil and all of those things. Personally, I love Ursula and I love the color purple, so I'm good with it. But, when we ingrain that in children who can't make those critical decisions or they start picking up those small cues, it really does matter.
Right. Now, Hans, I want to get back because you're our numbers guy today. Are the numbers going up over time? Are there trends there that we should be aware of? Aside from just the numbers going up, are there internal things that we like? Are there more kids, more women? Can you give us some sense of that data?
Yeah, definitely the numbers are going up. I mean, in the last decade, there's been about a doubling in the proportion of the adult population in Canada that lives with obesity. We're at about almost 30%. So that's over 10 million adults across Canada. But one of the more concerning trends, I think, is that at the higher levels of obesity, if you will, we have obese class 1, 2, and 3. There's a more rapid increase at the higher levels of obesity as well. And for folks living with that level of obesity, the consequences are even more dire. And then there was, this whole issue, with the epidemic that we've just gone through with COVID, which I think has had a significant impact on people as well in this space of excess weight.
Okay. Now, Mega, I want to, we've been amazing. We haven't yet talked about the elephant in the room, the GLP-1 inhibitors. These are a big deal. So I wanted you to start just giving us some context. How important are they? And then we'll talk about other things other than drugs.
Sure. Yeah. They're extremely important. They're sort of a revolution in terms of our ability to finally be able to treat obesity. But when I look at what happened over the last decade, what was so interesting about GLP-1 receptor agonists was that they actually gave us permission to start to understand what the disease actually was about. Only once we start treating it, all of a sudden, you could even see it in my patients' voices and how they describe treatment. Is this what other people feel like? Like, is this food noise something that I just lived with and I never knew existed? And so when we talk about obesity as a chronic disease, we're really talking about the appetite system. That's what's really making our bodies hold on to their highest weight and that set point. It's all driven by the appetite system. But that's a really hard concept to understand when you're just kind of using lifestyle modification as your treatment. Only when we started treating the appetite system, which GLP-1 receptor agonists do so profoundly, all of a sudden, all the pieces of the puzzle kind of came along beautifully. Now we can explain the disease, we can treat the disease according to its pathology, and that's why we're now seeing such a great benefit in terms of it. But they're not a magic solution, right? So GLP-1 and any obesity treatment is treating the biology. The biology of the appetite system is one part of the puzzle, but what it's doing is it's allowing us to live in this environment more and be able to manage our weight by staying at a lower weight. But all of the behaviors that are required, all of the behaviors that somebody's been working towards being able to do, they still need to be done. But when you're on a treatment for obesity, you're able to do those behaviors much more effectively and much more easily. And so, often we sort of say one or the other, or now just everyone's going to be on a prescription. Is that really kind of what we're doing? But it's simple to think that, but it's important to recognize that without treatment, behaviors that you want to engage in for your health are unlikely to be successful. The treatment actually allows you to be successful in those ways.
And just because we have a general audience, in the simplest terms, these drugs work. Essentially, you don't feel hungry. Is that how it works?
Yeah, it's so how these medications work. So GLP-1 is a natural hormone. We all have GLP-1 in our body. When we eat food, it lives in the second part of our small bowel. GLP-1 goes to our brain and tells us that we're no longer hungry. That's how it works naturally in our body. When you live with obesity, that signal is disrupted. So what ends up happening is if you're trying to lose weight and you're in a calorie restricted environment, your GLP-1 is not signaling to your brain that you're getting full. And so that signal never gets dampened. And so people are generally more hungry at baseline when you live with obesity. When you give a GLP-1, we're giving higher doses than your body would normally produce. And so that ability to live at a lower weight without being overly hungry is how GLP-1 also works. The other two mechanisms are really important. One is that it regulates insulin and glucagon. This is why they were such profound diabetes drugs and still are. They help regulate insulin resistance, which causes a lot of problems with fatty liver, diabetes, high blood pressure. It also slows down the passage of food through your gut. So when you've eaten a meal, you're actually staying full for longer. So it works very intensely on the appetite system, but it also works directly on the metabolic pathways that are responsible for negative consequences.
Right. Now, Lisa, what I'm hearing from Mega, I'm hearing, well, this is a brain disease, obesity. Is that the new message we should be getting out?
It's a message that I really enjoy, and it really seems to cut through as well. It makes people stop in their tracks and go, oh, let me think about this differently, because we're so used to thinking about it being forks and feet, what I'm putting in my mouth and what I'm not doing with my body. And this really, really changes the dynamic, and it helps people truly understand that this is about deep neural pathways. It has to do with our genetics, our environment. It was put in motion before I was a wee glimmer in my mom's eye, even how much of this I was going to be predetermined, because I have obesity on both sides of my family, and it has a really strong genetic prevalence as well. Plus, our environments are obesogenic. We know that we have not a great food system in North America, full stop. There's lots of opportunities in that. So we're not doing ourselves any favors along the way, but ultimately, yes, it is a disease of the brain that needs to be supported like any other chronic disease.
Now, when I write about GLP-1 inhibitors, I get two responses all the time. Oh, is everybody going to be on these drugs, and are we going to be on them forever? What do you say to those questions, Lisa?
Oof. I I worry about that a little bit, but I love that we're starting to have this conversation about looking at obesity as the chronic disease that it truly is, because that really is what's going to change everything. It's going to help us move away from that lifestyle conversation, and it should unlock a really different kind of system response as well. That being said, we can't get everybody on a GLP-1. We want to actually also recognize that this is really exciting time for people living with obesity. We have solutions that we've never had before, and that's different than somebody trying to get into a dress for their wedding potentially. So I was, my background is also being in marketing. For a long time, I was walking around going, obesity just needs to be rebranded. That's our biggest challenge here. Let's rebrand this. And now look what we've done. Toothpaste is out of the tube. The genie is out of the bottle. And we've kind of lost the narrative a little bit as well, because as Mega said, and I want to reiterate this, when it comes to obesity, there's no one cause, there's no one cure. This is not a silver bullet. And even for those of us that do have a positive response to them, it's still really challenging to get access. So that's a bigger problem that we need to be talking about than is everybody going to be on them and for how long. But again, I want to frame that how long part with for as long as you want to maintain a healthy weight, for as long as you want to be treating your chronic disease, which is likely going to be your whole life, you need to be in some level of care. That doesn't necessarily mean you're going to be on a GLP-1 for life, but you should be in care for life. I hope I did right by that, Mega. You're probably more astute to talk to the medical side, but yeah.
And I've heard you say before the analogy, you say you wear your glasses for life. What's wrong with using this drug for life? Absolutely.
That's one that I love to help people frame when they're feeling bad. And I even had this as someone with lived experience going, oh, maybe I should be tapering off, or maybe I'm ready to be off of this. And then I have to remind myself, no, when I take my glasses off at the end of the day, my eyeballs aren't smarter. It's not my body's job to learn from this drug. It is a tool in the toolbox to help me navigate life and be able to show up as the kind of Lisa that I really want to be.
And Hans, like me, you've been around a little while. We've been around the block. We've heard many miracle drugs come up over the years. Do you worry about this one having some negative consequences over the longer term, the promise falling through, as has happened many times in the past?
It has, yeah, and I think it's always important to look at long-term risks. But I think, maybe Mega can talk a little bit more about, the fact that this drug has been around a bit longer than maybe some of us think. It gets out into the press, and we think maybe it's only been around for a year or two or three. But my understanding is that it's actually been around longer and that there is a fairly good safety profile. But maybe Mega can talk to that a bit more.
Yeah, Mega, it has been around a long time as a diabetes drug. We're only now talking about weight loss, but it does have a good safety profile, right?
Absolutely. And not just safety profile for clinical trials, but in the real world. Like I have actually been prescribing these medications for over a decade now. They're not new medications. And the difference that I'll say, there has been a bad rap for obesity medications in the past. A lot have been, having to be pulled off the market. But this time is different for multiple reasons. The main reason is the number of people that use GLP-1s in the last sort of 3 to 5 years is remarkable. And that has never happened before, whether that's because of social media or whatever it might be. That exponential rise in use of these treatments has been very interesting because the real world data that has come out of millions, right? If you look at China and India and some of these sort of more populated areas, millions of people are on GLP-1s, and we're not seeing huge negative consequences. So I think that we'll see how that goes in terms of using it in obesity in people without diabetes, but we have pretty good clinical evidence and confidence that these are safe. And even if there are rare issues that come up, in general, the benefits still outweigh the risk. If the benefit is improving heart disease mortality, right, the number of years of life you actually have if you have heart disease, it's really hard to sort of outweigh that from a super rare eye disease, for example. And so that balance is what we look at when we think of, am I concerned that this person in front of me who I'm prescribing this for is going to have a negative consequence versus what do I think the benefit for this person will be? Usually it's an easy answer.
And Lisa, the cost question always comes up. These drugs can be expensive. How do we deal with that one to make sure people get this in an equitable fashion?
That one's a really sticky wicket. And right now it is one of our biggest challenges. And I think For me, my simplest answer to that is we need to start having the courage to have the conversations and the courage to really look at this differently. That is truly what is needed right now, because when we reframe this and we look at it as that chronic disease that also has a big factor on some downstream diseases, that should also help us get into this conversation and see the dollars and cents in a little bit of a different way. When we look at obesity as a chronic condition and treat it first and upfront, we can remove the potential ripple of over 250 other chronic diseases. And those right now are disease states where we're okay to spend that money. We're talking about heart and stroke. We're talking about diabetes and hypertension and osteo and knee replacements. What if we flip the script and we started treating people, which is, as Mega said, to me, also a form of prevention, sooner for their obesity, and see what we could do to remove some of those impacts and costs downstream? I think that warrants a really good conversation and study and review. And then we need to talk to our governments as well and say, how can we say that this molecule that treats a chronic condition like diabetes is covered and supported, but over here it is not when we call it obesity, but we're saying very similar things. We know that this is a deep genetically inherited disease. We know that this is beyond the control of most people with their own mechanisms. Everybody should be invested in diet and exercise, and we all want that to be a vibrant and healthy Canada. But if we're blocking a treatment for a chronic condition because of dollars and cents, we're really missing the point. So I don't have a silver bullet for this one either as a solution, but if nothing else, can we have the courage to talk about it and the courage to think bigger and act bigger, because there's so much more to obesity than what meets the eye. We have to start thinking about it differently.
And we have a lot of questions coming in from the audience. I'm going to just throw them into the conversation rather than waiting for the end. People are wondering, with GLP-1 inhibitors, does that take everything else off the table? Is bariatric surgery still important, for example? That's a question that's come up a couple of times.
Yeah, it's a great question because our newer agents like tirzepatide are quite effective, and the degree of weight reduction almost can overlap the degree of weight loss with bariatric surgery. But bariatric surgery is not going anywhere. Not that many people actually get bariatric surgery for treatment of obesity. It is still our most effective tool for the most amount of weight to be sustained off long term. There is always going to be a role for obesity. It's a chronic for bariatric surgery. Obesity is a chronic disease. Even after you've had bariatric surgery, you may still need medications to treat obesity. So it's going to still have a significant role. One patient population that I'll describe is those who have type 2 diabetes on insulin. There are very few treatments that have been shown that you can come off insulin and still have your diabetes well controlled. Bariatric surgery is one of those. So there is going to be a patient population that we're going to prefer bariatric surgery over medication. However, surgery is not a scalable or effective tool for the average person. Not everyone with obesity needs bariatric surgery or will get it. But medications, all of a sudden, we can bridge that gap. If we're thinking about 1 in 3 Canadians, that's not going to be 1 in 3 Canadians that are going to get on medication, but far more people will be treated than if we just had bariatric surgery.
And hence, are we doing a good enough job of collecting data? We heard there's millions of people starting to take these drugs. Are we doing enough work collecting the data that will inform how we use these products properly?
It's always a really good question. There's a lot of data out there sometimes, but often I say there's not very good information, right? Sometimes you have to pull it together in a certain way. But if I may just talk a little bit about the costs of the treatment and put that in the context. One of the reasons we look at economic burden is because we know there is a cost to treatment. And so if we're treating and if we're reducing, the number of folks living with obesity and therefore reducing the number of hip replacements, et cetera, the diabetics and heart diseases, et cetera, we need to put the context of the cost of the treatment in terms of the economic benefits of that treatment. And that's a lot of work that we are continuing to still do, working with the Ministry of Health here in British Columbia, for example, looking at clinical prevention, looking at things that are not only effective, but cost effective. And so, if a treatment's effective, we need to look at it in that context as well. So it's not just about the cost of the treatment, it's also about the economic benefits of that treatment as well downstream.
But not to be too cynical, but I know every drug in history promises big cost savings, and we rarely see them. Are we going to see them here?
It's not an area that I've looked at in detail, but if the impact is as big as Mega is talking about in terms of that population, then yes, I think we would see them. The challenge is that we don't see them right away necessarily, right? They don't happen the year you start taking, although some of them might. But longer term, you'll start seeing a reduction, in heart diseases. You'll see a reduction in diabetes. You'll see a reduction in back problems. You'll see a reduction in colorectal cancers, et cetera. And all of those things cost money to treat as well. And those are all side effects, if you will, or consequences of living with obesity. So we need to sometimes take the longer view. We can't just look at it, 1 year over another. We need to look at the downstream costs that we're avoiding, as well as the actual cost of the treatment up front.
And Lisa, I'm wondering, I'm starting to read sort of some pieces now about these drugs inadvertently increasing stigma. So people just saying like, how can you be overweight? All you need is this shot. Is there a danger that it'll make the stigma worse or different?
That's a real concern that we need to be mindful of when we reframe it away from that personal choice and willpower and into that chronic disease. It's a really powerful and necessary shift, but it definitely doesn't come without its risks, because if we're not careful, we can swing from that obesity is your fault to why haven't you fixed your obesity yet? And that is still just as problematic. There's a lot that we still don't understand. Obesity continues to be a bit of a quagmire in that we aren't diagnosed by one organ. And we also can't say that everybody living in a bigger body is living with obesity, or that anybody living in a smaller body doesn't have obesity. So there's still a lot of nuance to this. But we really do need to be mindful, because if we don't center or bring into the conversation some elements about body diversity and also body autonomy into the conversation, we're only going to perpetuate and create new forms of stigma as well. So that's something that I'm really mindful of along the way in this journey. And again, diet culture is mine enemy. And I mentioned it once more because it has also told us that we all should look the same and we should be able to get to the end of life and kind of be able to fit into our genes from high school. And I share a different opinion personally. I want to get to the end of my mortal coil, and I want to have scars and stories to tell and experiences to have. And with that, your body is going to change. So I just want to level set that in a bit of the conversation as well. And really, we need to understand that kindness actually should be a huge Canadian value that we don't lose sight of along the way too. We need to stop judging people for things that they can't control. We need to get back to being kind to each other and just recognizing that, again, body diversity is an okay thing along the way as well. It's about, are you healthy? Are you happy? Are you giving back to society?
And you can be heavy, you can be large, and you can be healthy, and the opposite. You can be thin and unhealthy.
Very much.
And Meg, I promised earlier to come back to that very point. You said in passing, I promised to come back, that it's not just about weight loss, what you do. Obesity treatment is not just about weight loss, it's much more. Can you expand on that a bit?
Yeah, absolutely, because it actually ties a lot of what we just talked about together. So if you think about the cost equation, if you take everyone with an elevated BMI and you put them on GLP-1, that's not going to be cost effective. We're actually not going to see improvement in outcomes, because we've now defined obesity just based off BMI. But if you take people that have inflammatory adipose tissue that's leading to an impairment in health, and you treat all those people, that's where you're going to see the economic improvement. And then to Lisa's point, if we start defining people and valuing them based on how they look, of course, everyone's going to want to get on a GLP-1 to look a certain way. And so it's because we have to keep going back to this definition. What are we actually trying to do? And the economic impact and the overall sort of self-confidence impact is going to come from separating out how much you weigh from who you actually are. And that is the true treatment of obesity. It's not going to be about how many pounds am I going to lose. It's going to be about, how do I feel? What am I trying to do? Who am I going to show up as? And it's so interesting because those are softer metrics. That's why it's so hard to put an economic value on it, because what does that even mean from a systems perspective? But that's why it's so important that people like Hans and Lisa and I were all on the same conversation, because we need to come together and show the data to support that when you treat obesity and you don't have to look at outcomes in a weight loss perspective, you look at it in terms of inflammatory adipose tissue, or if you're improving that and improving movement, self-efficacy and confidence and happiness, what does that equate to on an economic numbers perspective? The other challenge that we were talking about was cost. And so, why is it so difficult to get these medications approved by private health insurance or public payers? It's because we need to start looking at hard outcomes, and the data needs to support that. So probably the first ever obesity medication that's going to be publicly covered is going to be for established cardiovascular disease, because we now have a clinical trial that showed if you go on to a certain obesity drug and you have heart disease, your chance of having another event is 20% less when you're on these medications. That's a real hard numerical economic benefit that you can attribute. So where we're going to start to see improvement in access is going to come back from this definition of, we're not trying to make people lose weight, we're trying to prevent them from having heart attacks. And that's how we're going to start to change the story.
Yeah, and if these drugs are as effective as statins, should we use them as widely as statins becomes the question. Yeah.
Exactly.
Great. Now I want to dive in because we have some really good audience questions. I have another one for you, Mega.
Yep.
It was about children. How do you treat childhood obesity in a compassionate way that minimizes harm? Because we know it's particularly difficult for children.
It's so difficult, and it's a great question. And Lisa mentioned the pediatric guidelines that came out. Probably the two revolutionary things that came out of that guideline. The first one was this idea of asking permission. So Lisa actually put it so beautifully. People were talking in the room around me. Children hear and see everything, and they will absorb everything. So first and foremost, it's about bringing all people involved in the room together, parents, families, and children, and asking permission and sort of being very open and vulnerable about the reality that your body size is not what we're worried about here. It's your health, and kind of reframing it in all those same ways. But the other challenge there is it's a family conversation. It's not one patient in the room when it's pediatrics. They're typically, the child is not making the decisions around their environment. So we need to kind of merge together the family so that the parents don't have the guilt, but they also have the tools to be able to support the child. Explain to the whole family how obesity is a chronic disease, how much of this you can control versus how much of it you can't, and then give them the tools to be able to support the things that they can change in a non-stigmatizing way. I think a lot of my adult patients living with obesity have stories of how their parents treated them in childhood. And so if we can start to kind of improve that narrative, then that internalized bias doesn't happen in the child. And then all of a sudden, we're going to be more successful. We actually have bariatric surgery that's approved in adolescents, and we have medication treatments that are also approved in adolescents between the age of 12 to 18. So we have safety and efficacy data on treating this patient population, but they're probably far less treated than even adults.
And Lisa, one thing we didn't talk about that I thought of when Mega was just talking was the mental health aspect. This is difficult, especially for kids. They're being teased, they're being ostracized. That has a lifelong impact on them.
Massive impact. Absolutely. It's the beginning of that charting the course of the stories that we're telling ourselves. It's the whispers that we feel like we have around us in the room, and it can feel that really pejorative voice in the doctor's office talking to us as well. So absolutely, mental health component is a really big and important factor of this. When we talk about the clinical practice guidelines and our recommendations for treatment, there's three main treatments, and we've talked about two of them already on this panel today. We've talked about surgery lightly. We've talked about the pharmacological aspects. The third and really most important pillar is that mental health support and cognitive behavioral therapy. You really need to be engaging in one or more of those treatment pillars before that diet and exercise is even going to pay off as well. One of the things, as someone who has lived with obesity her whole life, you lose your connection with your sense of self. And I often think that that is a first place where people see a massive change when they're on treatment as well, is they're like, oh, I can actually start believing myself and trusting myself again as well. And that's a huge component of this. And that really is what allows us to show up more fulsomely, again, in workplaces and in our communities and in our families. And that's the kind of Canada that we want to be.
And Lisa, I have a tough question for you too. One of our viewers said, you talked earlier about the need for a collaborative model for obesity care. They want to know, how can you advocate for that, and how likely is it that we're going to get it?
Yeah.
I'm hopeful. I am very hopeful about this. And again, it's unfortunate that right now the best thing that we can do as individuals is be really informed and strong advocates for ourselves. So you can create your own collaborative network, but that means that you are going to be the one that are connecting dots and introducing people. It's possible. But all of this starts again with courage and conversation. We have to start showing up and being loud together. We need to be able to start having these conversations. So to that and Obesity Canada, we have a current petition running on our website where we invite everybody to let their MPs and their federal or provincial representatives know that obesity is a chronic disease and it deserves to be treated as such. Helping us with our voice being louder and more collective together on those big push moments is really important. And then the individuals come to our website. We've got great patient resources. We've got the Know Your Rights so that you can really understand what it means to navigate your own care as well. Know that in the background, we're also pushing for larger conversations so that we can get this on a more systemic level, because that's truly what's needed is a systemic change.
Great. And Mega, we're getting into the nitty gritty. People have some really sophisticated questions, so I'll throw a couple more at you.
Sure.
I'll bundle a couple together. Are there pre-existing conditions that make people less ideal candidates for GLP-1s? And secondly, do they work for things like people for food noise, like binge eating, for example? Are these effective?
Mm-hmm. So less ideal candidates are those that are more likely to have adverse events or side effects. So if you've got a rare type of thyroid cancer called medullary thyroid cancer, you or anyone in your family, these are not going to be good agents for you. If you've had chronic or recurrent pancreatitis, these are not going to be good agents for you. People that do less well. So if you look at all the clinical trials of GLP-1s, the patients that do less well are those who have had type 2 diabetes for a long time and are on insulin. And men actually respond a little bit less well than women do, interestingly, just from a weight loss perspective. But these are not contraindications. These are just interesting sort of scenarios. I would say majority of people will do well. There's only those two contraindications. If you have those two, you can't be on GLP-1s, and then pregnancy and breastfeeding. Those are also not going to be an option for you. Any obesity treatment wouldn't be an option in those situations. And then the second question around binge eating. So binge eating is a really interesting challenge that overlays with obesity because guess what? It's also centered in the brain. And it's a very interesting correlation between how our brain thinks about appetite for survival and how it gets turned into overconsumption or binge eating. There's actually two different parts of our brain that regulate the appetite system. Binge eating is more an increase in dopamine and the reward and pleasure we get from food, as opposed to just a drive for hunger. And so GLP-1s, for example, are effective at improving hunger and some of the reward pathways, but we actually have other medications that directly target the reward pathway and dopamine. Contrave is one that's an obesity medication. Vyvanse, which is also an ADHD medication, interestingly, is the only Health Canada approved medication for binge eating because it's a stimulant that directly targets the reward pathway. So important correlation between obesity and binge eating. You have to treat both, but often when you treat one, binge eating does get better.
And Lisa, there's some questions too about not obesity, but just being overweight. Women in menopause gain weight. As we get older, we gain weight. Should we be concerned about this, or is this just normal, in quotes?
Oof. I don't know if I'm the right person to answer that. But again, I say bodies do change. As a lady who's also 50, I hear you, I see you, and I feel you. And I think we also need to be more courageous and talk about just that fact as well, that, women's bodies do go through an entire other phase of life, but that could be a completely different panel for you and I, Andre, to have. But, again, be kind to yourself. Bodies are meant to change to a degree. It's really, let's remember what we're talking about. It's not the number on the scale. Let's think about our core values and is it impeding you from being able to do things in your life? Is it impacting your blood pressure? Is it impacting your osteoarthritis? Those are the conversations to have more than focusing on that number on the scale. That's really what I want people to understand and see as well.
And Megan, maybe I should ask you, should women on menopause, they start gaining weight? Are these drugs right for them, or is that just life?
Yeah, it has to be worth it. right? Because what these medications mean is truthfully, probably long-term treatment on a medication that's going to allow you to live at a lower weight. But is it worth it for you to be on this medication long-term, given that sort of history? Not not everyone that gains weight in menopause has obesity, as Lisa sort of well said. So from a worth it perspective, I can help counsel you on whether it's medically worth it. If you've got no issues with your blood sugars, no issues with your mobility or your appetite system is well controlled, I would say from a medical perspective, probably not worth it, because all it's allowing you to do is live in a lower weight body. But that could be different for you, right? So if it's worth it for you, then as long as it's safe to be on, that's a you decision. But it has to be a collaborative conversation to know, what are you doing? What are the risks? What are the benefits? My job is to give you all the information. Your job is to make the best decision for you. And I think that's going to just be an individual decision.
Now, we're almost out of time. I always like to end panels on a hopeful note if I can, especially in these pretty dark times we're living through. So I want to ask you, before we sign off, are you hopeful, or what makes you hopeful the treatment for obesity is going to get better in the future? And maybe I'll start with you, Hans. We've been ignoring you for a while. What makes you hopeful?
I mean, just even hearing what, again, I'm not a physician by background, and hearing what I'm hearing today from the other panel members makes me hopeful, I think, in terms of both, how we look at excess weight or obesity, and people living with that, and some of the medical options that are available out there. I think that is hopeful. That is hopeful.
And hopefully those numbers you gave us at the outset, the 54 billion, hopefully those will come down a bit, and we'll use that money elsewhere.
Right. Yeah.
Mega, we've had a lot of questions for you today. How do you stay hopeful in this very rapidly changing field?
Yeah, it's easy for me to stay hopeful because I have seen a dramatic improvement in people's lives every single day. It's not just about the medications that bring me hope. It's people like Lisa. When she started up at taking over at Obesity Canada, all of a sudden the conversation really sort of changed. I see it in my patients. I see it in people around me. I also see it in all of the collaborations I'm working with, whether it's in digital health tools or pharmacies, or, everyone has sort of got this fervor of all hands on deck. And I'm only going to be hopeful that this is going to move the needle forward at helping people manage their disease, but doing it safely, but also in a stigma-free way.
Okay. And Lisa, the last word, an advocate, someone with lived experience. You sounded hopeful all day.
I am, and I am incredibly hopeful. To me, what's giving me hope is that we are truly standing in a once in a generation moment and an actual opportunity to get something right on a really large scale. So I'm incredibly hopeful for that. I'm also not a shy lady, so I'm willing to go meet any of the new ministers or anybody who's willing to sit down and talk about this, because we finally have the data. We have clinical guidelines that are the gold standard. We know how to do things. We have solutions now. We have breakthrough medications. And I also want to give a shout out to Canada in general. We've got a lot of the pioneers about understanding obesity, about discovering these molecules right here on our home turf. We also now have the cost of inaction study and people like Hans that are looking at this from an economic point of view that's telling us that doing nothing is costing us everything as a nation. We really need to understand that. We're keeping ourselves off the table, and we need to start by getting people back in action as well. So the other thing that makes me incredibly hopeful is we've got more voices now than ever. We've got healthcare practitioners who are starting to understand it and who want to make change. And we have people with lived experience, people who have often not been seen, who have tried very hard to not take up space and to be an inconvenience, showing up for themselves, as themselves, asking for better, and asking that we change this game. So what we need to do is make the right thing to do, the easy thing to do. We need to help give access. We need to help give training to providers. We need to think about systems changes. And that's also a moment I'm incredibly hopeful about. We're not asking people to change. We're talking about systems needing to change. And that's big. We've crossed to a different level now. And that is our really big opportunity. And that's where we can unlock that full potential. And we can get people back into the right workforces. We can get people engaged in healthcare in the right ways for their wellness, but they can also get engaged in their families and their communities. And that's what's really the biggest opportunity for me right now. I think we can be elbows up while taking care of everybody inside our elbows.
Great, a great note to finish on. I'm glad you also mentioned the Canadian connection, Daniel Drucker, who discovered GLP-1 20 years ago, and it's really come to life in recent years. So unfortunately, that's all the time we have. As you said, Lisa, there's a couple of things here we could have a whole different panel about. Maybe we'll think about that. But on behalf of the Globe and Mail, I'd like to thank the three of you, Dr. Megha Poddar, Lisa Schaefer, and Hans Kruger, for joining us today from around the country. Thank you to all our audience members for attending, for your great questions. Sorry we didn't get to all of them. And of course, I want to thank Eli Lilly Canada and Obesity Canada for supporting today's event, making it possible. For people in the audience, we'll be sharing a link to the recorded webcast in about a week. If you registered, you're going to get a link. In case you missed it, you want to share it with your friends, it'll be there. So thank you again, everyone. Enjoy your day and live healthy. See you next time.